So care of women with obesity in pregnancy. This is a green top guideline number 72. Now this particular obesity is actually is a part of all modules what we are going to discuss. So today we will keep our discussion minimum restricted to the obesity, the part which is not covered along with the other modules. Like when you will discuss venous thromboembolism, then obesity and venous thromboembolism, we will have a specific discussion at that particular time. When we will discuss about contraception, so what are the issues in obese women, that we will go into further details. So our discussion will be isolated points which are covered in this particular guideline, while rest of the things we will discuss when we will consider the particular guideline. So what they talk about pre-pregnancy care for women with obesity. First is a weight optimization opportunity. All women of childbearing age should be supported to optimize weight before the pregnancy. The routine advice should include the weight and lifestyle advice during preconception or contraceptive consultation. You have to monitor the weight and BMI. Measure BMI to encourage weight optimization before conception. Then risk information you have to tell. If the woman has got more than 30 or equal to 30 BMI, they should be informed about the pregnancy and childbirth risk related to the obesity. They should be supported for weight loss and support weight loss in line with the NICE guideline before conception and in between the pregnancies. Benefits of the weight loss are it reduces the risk of stillbirth, hypertensive complications, fetal macrosomia, and it increases the chances of successful VBAC. Okay, so when we will discuss about the VBAC, the success rate reduces in obese women. We will see how much is the success rate in obese women for the VBAC. Now this classification also you should remember, okay, because they ask you this particular class, to which class the patient belongs, and especially the borderline one. Say for example, underweight is below 18.5, normal is 18.5 to 24.9. Remember, so 25 is not normal, 25 is here in overweight and pre-obese category. Okay, so normal is 18.5 to 24.99, and 18.5 less than 18.5 is underweight. Okay, so if you are asked about this, less than 18.5 is a normal, okay, but less than 18.5 is underweight. Okay, and 25 is not normal, 25 comes in the overweight category, especially in the pre-obese. So pre-obese between 25 to 29.9, then obese is class 1, class 2 and class 3, 30 to 34.9, 35 to 39.9, and 40 or more is a class 3 obesity. Now regarding the supplement, what advice they say, folic acid is to be given for these obese women, 5 milligram per day, start at least 1 month before conception and continue through the first trimester. Okay, so folic acid should be supplemented for these women. Okay, vitamin D can be considered. So vitamin D is, so even if both options are given, this is recommended, and this they say that you consider. Women with obesity are at high risk of deficiency in supplementation may help, but the evidence on improving outcome is unclear. Okay, so this is what the guidelines says about the supplementation. Now antenatal care for women with obesity, what exactly they are talking about. These services, these women are to be their services are to be integrated with the routine antenatal clinic only, no separate clinic, but you have to integrate into regular antenatal clinic, but specifically focused advices should be given. So if her BMI is equal to or more than 40, then third trimester moving and handling assessment is required. So this will be in addition to other women. Okay, what you have to do, her movement and handling assessment. Okay, because if the patient gets admitted, how you are going to shift from one labor ward to the theater and all these assessment you need to consider. Ensure clear communication between the labor and theater teams. Okay, and if the BMI is less than 40, assessment may be needed case to case basis. Okay, so more than 40 you have to do this assessment. Okay, but if it is less than 40, case to case you can decide. Then what is here is a SBA. Okay, they have asked this in the past. What is the prevalence of obesity in antenatal population? And they will give you a number of figures and you will get confused. Okay, so obesity is a common obstetric risk factor. 21.3 pregnant women are obese. Okay, remember, or they may give 1 in 5. You remember some figure which is somewhere between 20 and 25, and then the options are like 1 in 5, 1 in 7, 1 in 8, etc., etc. So they may give this same figure as a 1 in 5 also. So 21.3% of pregnant women are obese, and only 43 point. How many women have a normal BMI at the time of booking? It is less than 50%. 47.3% have a normal BMI at the time of booking. Okay. Now, this is not much important, storage and transport equipment, storage and safe transport facilities, etc. But you need to check essential equipments. When such patients are registered with you, you need to have large blood pressure cuff, then weighing scale, large armless chairs, large wheelchairs, ultrasound scan coaches, delivery beds. They should be suitable for these patients, and you need to check the availability of all these. Then initial measurement. So measure the weight and height and BMI one at the time of antenatal visit using suitable equipment. Record in both handheld notes as well as electronic system. Then when you will reweigh in pregnancy, consider reweighing in the third trimester to plan equipment and staffing needs for the labor and birth. So when how you are going to plan the labor of this particular patient. So reweighing is recommended in the third trimester. What about the gestational weight gain? There are various books which mention, but what the guideline says, there is no clear consensus. Emphasize healthy diet over strict weight gain targets. So there are no specific strict weight gain targets for these women which are mentioned in the guideline. Okay. Now, what are the risks of obesity? Okay. Provide clear, accessible information on maternal and fetal risk. Offer opportunity for discussion. Diet and exercise, what do they say? Offer early dietetic advice from the trained professional, and anti-obesity drugs are not recommended. Okay. And another important thing which is asked in the SBA is here. Okay. So what you have to do is you have to carry out anesthetic assessment. So women with more than equal to 40 kg per meter square should be referred to obstetric anesthetist for antenatal assessment. So in antenatally only you will refer these patients for obstetric anesthetist. Okay. Evaluate potential issues with venous access, regional and general anesthesia. Document a clear anesthetic plan and involve multidisciplinary team if needed. So antenatally you will get this particular reference done if she has got a BMI of 40 or more. So in this particular case, they may ask you, following is one of the important thing with a BMI of 40. So this obstetric anesthetist review for venous access, regional or general anesthesia. So they will find out what exactly the difficulty, counseling of the patient will be done, and everything will be documented in the notes. And another important thing is a pressure source prevention. If the BMI is equal to or more than 40, then you have to do in third trimester tissue viability assessment using a validated scale conducted by qualified professional. So there is a these patients are prone for development of pressure source. So there is some validated score and the scale which is to be used, and that is done for the tissue viability assessment. So these two things, for pressure source prevention, tissue viability assessment, and anesthetic assessment. So these are the two things which we have to carry out for these patients. Then coming to the screening, what you need to do the screening here, just remember the cutoffs. Okay. So gestational diabetes. So screen all women with BMI more than or equal to 30 kg per meter square as per the NICE guideline or SIGN guideline. So if the lady's BMI is more than 30, you will screen for GDM. Okay, not like us, they are screening all patients for GDM. There needs to be indication. So one of the indication is BMI more than 30. And for hypertensive disorder, the prophylactic aspirin is to be started. But when it is to be started, use appropriately sized BP cuff at all visits and document it. Class 2 obesity, that is BMI more than or equal to 35 and above, increases the risk of preeclampsia. Women with more than one or equal high risk factor. If a lady has got one or more high risk factor, that is BMI more than 35, age more than 40, first pregnancy, family history, or multiple pregnancy. So if she has got any of these two, then you have to start 150 milligram daily aspirin from 12 weeks until birth. Okay. So remember here, BMI more than 35 is the one of the criteria. While for screening for gestational diabetes, BMI more than 30. Okay. And high risk for development of preeclampsia and starting of the aspirin, BMI more than equal to or 35, age more than 40, primigravida, family history of preeclampsia and multiple pregnancy. If any of the two are present, you will start 150 milligram daily from 12 week onwards until birth. Okay. Now, venous thromboembolism. BMI more than 30 kg per meter square is a pre-existing VT risk factor. Perform VT risk assessment at booking during admissions, intrapartum and postpartum. This we will go further into details when we will discuss about the VTE guideline. Okay, guideline number 37A and 37B are related to that. We will discuss that time. Then mental health, BMI more than 30 kg per meter square increases the risk of mental health issue. So we have to screen. No specific lifestyle intervention is proven for prevention of anxiety and depression. Chromosomal screening is routine. The same antenatal chromosomal screening is offered to all women. Inform that the screening accuracy may be slightly reduced with higher BMI, and consider TVS if the NT, nuchal translucency, is hard to measure abdominally. Okay. Now, what they say about the structural anomaly screening. For structural anomalies, offer standard screening tests. Counsel women that obesity reduces the accuracy of structural anomaly detection. That you need to specify. Then fetal monitoring from 24 weeks onwards, measure symphysiofundal height at each visit. So from where the SFH used to be measured, from 24 weeks onwards. Okay. In women with BMI more than 35 kg per meter square, SFH may be inaccurate and refer for serial ultrasound. So if the lady's BMI is more than 35, SFH, symphysiofundal height, is may be inaccurate, and you will refer them for serial ultrasound. Use ultrasound to assess fetal presentation if palpation is difficult. Okay, so here comes the role of serial ultrasound. So SFH is indicated after 24 weeks of gestation. If BMI is more than 35, apart from SFH, you will refer her for serial ultrasound. Okay. Then fetal monitoring and labor planning, in what they say for intrapartum monitoring, we will follow the guideline. We will discuss these guidelines separately. Then post-date monitoring, there is no specific recommendation. Inform women with obesity that there is an increased risk of stillbirth after the due date. Okay. Labor and birth planning, discuss and document labor and birth plan with obstetrician. Birth setting, now this here there can be SBA. So low risk multiparous women can be offered birth in midwifery led units with a clear referral pathways to consultant led units. So if she is a multiparous without any associated risk factor, like there is no preeclampsia, no GDM, this lady may be offered birth in the midwifery led units. Okay. But they should be informed about the clear pathways to consultant led units that they may require a referral to CLUs. Okay. Then third stage management, recommend active management to reduce the postpartum hemorrhage. Okay. Now, what does the guidelines say about the induction and cesarean in obesity? For induction, it may increase the risk of cesarean without increasing the adverse outcome. Discuss individually with each woman. So that is one-to-one decision is to be taken. Maternal obesity in cesarean, not an automatic indication. Obesity per se is not an indication. So there has to be multidisciplinary decision based on comorbidities, complications, and woman's preference. So decision for cesarean section is always a multidisciplinary. Then what about macrosomia and obesity? If macrosomia is suspected, induction may be considered. Discuss induction versus expectant management with the parents. Okay, so if there is a macrosomia, consider induction. Okay, you have to discuss induction versus expectant management. Then further, what does the guideline say about the previous cesarean? If she is for VBAC, women with more BMI more than 30 kg per meter square should have individualized VBAC plan after informed discussion. Generally, the VBAC rate, success rate is reduced in these patients, so that should be taken into account. Then place of birth. Class 1 and class 2 obesity alone is not a reason for CLU. Okay, they need not go for consultant led unit. Discuss risk and CLU advantages to support informed choice. So you can discuss what place of birth you need to offer to these ladies. Okay. Then anesthetic communication. Here also there can be a question. So inform on-duty anesthetist when a woman with class 3 obesity is admitted. Midwife should document this. So this is one of the important things. Even if the lady gets admitted in a early labor, you have to or the midwife has to inform the on-duty anesthetist. So for class 3 obesity. We have already seen antenatally we have got a reference done for obstetric anesthetists, but even if such lady gets admitted, you have to inform and document it. Then midwifery support. Women with class 3 obesity should have continuous midwifery care, take steps to prevent pressure sores and ensure effective fetal monitoring. Labor interventions for BMI more than 40, establish early venous access, consider second cannula, recommend active management of the third stage due to the increased risk of PPH. Okay. Then coming to the surgical techniques for cesarean section. Surgical techniques, individualization, no specific method as such. Antibiotic prophylaxis, women with BMI more than 30 or class 1 obesity should receive prophylactic antibiotics during surgery. Then subcutaneous closure, this is important. If you have got a more than 2 centimeter subcutaneous fat, suture the fat layer to reduce the wound infection and separation. Okay. Wound care technique, no strong evidence to support routine use of negative pressure dressings and barrier retractors or subcutaneous drains. So for wound care, drains, subcutaneous drains, there is no strong evidence. Okay. Negative pressure dressing, no strong evidence. Barrier retractors, no. But more than 2 centimeters subcutaneous fat, you have to suture the fat separately, okay, to prevent the wound infection. So this is what you can remember from this. Now, postnatal and follow-up in patients with obesity. Breastfeeding, generally these patients have a low rate of breastfeeding. So provide a specialist antenatal and postnatal support and improve the breastfeeding rates. Then postnatal contraception, consider maternal obesity when choosing contraceptive methods, that we will discuss along with the contraception guidelines. Long-term health advice, weight reduction, nutritional advice, gestational diabetes follow-up. This we will discuss along with the NICE guideline. Then weight management, support postpartum weight loss, offer referral to community weight management services, etc., etc. Now, pregnancy after the bariatric surgery, this can be asked as a question. Now, when should this patient conceive? Okay, if the lady has undergone bariatric surgery, wait for 12 to 18 months post-surgery before conceiving to allow weight stabilization and manage deficiencies. Okay, antenatal care, pregnancy is considered high risk and provide consultant-led antenatal care. Remember, here, if the lady has undergone bariatric surgery, even if her BMI is reduced now from the previous, she will be under the consultant-led care. While class 1 and class 2 obesity without bariatric surgery may accept the MLU, that is midwifery-led unit. Is it clear to all of you what we are discussing? Bariatric surgery?
Yes, sir.
Okay.
Yes, sir.
Wait
Yeah,
for
yeah.
12 to 18
Yes.
months.
Yeah. Then nutritional monitoring, conduct nutritional screening for deficiencies during pregnancy, refer to dietitian for specialized advice. So these two are little different things. Huh? Don't get confused when you read the question. No, her BMI has lowered down from class 3. She has landed up with class 1 now. Can she go undergo midwife led? No, no. She has undergone the bariatric surgery. She will be in the consultant led, and she should not conceive 12 to 18 months post surgery. Okay. So these are the minor points which you need to take into account. So that finishes our GTG on the obesity in pregnancy. Okay, thank you all.